Okay, thank you very much again for your lovely warm welcome. I'm going to shift the focus a little bitty. I want to look at measuring light dose if you're doing PDT. I think it's important if we are doing PDT that we know how much light we're giving. Now, in many respects, the answer to the question is how much light do you need to give? The answer is enough. That's fine. But how do you know if you've given enough? You need to have some way of at least measuring what's coming out of your device and then having some estimate of what's going into tissue. So I want to look at these two different aspects this morning. Just simple ways of measuring what's coming out of your device and then trying to see if we can predict what light is going into tissue. And on the basis of that, you may wish to alter what you're doing clinically because of the work which I'm going to describe here, we have already changed our clinical practice. So although this is about measuring light dose and predicting light distribution, it's not an ivory tower exercise. This is done for real practical reasons because we want to make our treatments better. And by adopting this approach, we hope to be able to improve on treatment outcomes. If we're getting 90% success, that's good. But what about the other 10%? Why can't we do something for the other 10%? And that's the challenge that we always have when we're doing any work. It's just to constantly try and get things better. We're going to start off with some very basic dosimetry. This is a very old Diomed, but what I like about it is you can see very simply this integrating sphere which sits on the top of it. And of course, if you put a fiber inside, this is a sort of fiber which we would use, for example, for treating PDT in the lung. So you have a diffuser which can be 1, 2, or 5 centimeters long, and the light is being scattered. And that's the sort of diffuser you would use for systemic treatments of PDT. And of course, what you can then do is pop that into the integrating sphere. Now, the thing is, you have to do something like that to measure light from a diffuser. You have to have some way of collecting all the light. Otherwise, it's very difficult because light is coming out in all directions. So the idea of an integrating sphere is that the light bounces about inside this sphere. It's coated with a white, highly reflective coating. The light bounces about, and there's a little aperture in the corner which takes off a certain percentage of the light. And the basis, and based on that percentage that comes off, you can then calculate the total amount of light that was delivered by the fiber. So you can say, yeah, I can now say I've given 1 watt, 2 watts, 3 watts, or whatever. And that's the reason that you use an integrating sphere to collect all the light from a diffuser. This is a way that we treat lesions on the skin. If you're using a laser, then there's a little micro lens on the top which gives you quite a nice, smooth, slowly widening beam. It's not quite collimated, but it does allow you to alter the beam width just by pulling the fiber away a little bit. So in this case, we don't have a diffuser at the end of the fiber, so we have to use a different sort of technique. In actual fact, it's much simpler in this case to measure what's coming out the fiber. Because all you need to do is use a simple laser power meter, and provided you only fill about half to 2/3 of the surface of your thermopile, then you can easily collect all of the power coming out of the fiber, and you can make corrections for the amount that is reflected. So again, with some very simple equipment, you can now say, yep, I can measure how much power is coming out the end of this fiber. So integrating sphere if you're using a diffuser, or a simple power meter if you've got an end of fiber delivery, and you can now begin to say with confidence how much power is coming out. And you might say, but doesn't the machine tell me? Well, this is the indicated power on the machine. These are different fibers with micro lenses that we have in use, and this is the actual power that is delivered. And there's a nice linear response, but although the machine may see 1 watt, you may only get about 0.5 watts or 0.8 watts. So if you actually want to know how many watts you're delivering, it's a very simple measurement to do. You don't have to do it every time. We have a protocol. Everything we do is protocoled. We have shelves full of protocols, which means that I can drop down dead and it wouldn't make any difference. Eventually somebody would notice I'm not in my room, but apart from that, the work would carry on because that protocol says every 3 months, measure what's coming out the fiber, and you produce one of these curves or one of these lines, and then just adjust the machine accordingly. And of course, all the fibers are a little bit different because some fibers have got higher efficiency than others. So it's quite important to know this. And fibers do degrade over time. And there comes a point of time where eventually you have to say, throw it away, it's only good for experiments. So that goes into the lab. It's not used in patients anymore. So the lab people can start using the fibers. It's cheap, it saves money. You use up your old fibers, and the lab people don't mind. Well, at least they haven't said that they minded, so that's okay. So that's fine. Very simple, very easy, very worthwhile to give you a good measure without much difficulty on how much power you're actually delivering. So what do you do if you've got an LED array? Because if you're treating a skin tumor, the chances are you're using one of these kind of devices. This is a company called Actolite. There's several on the go. There's a 16, which has got 16 diodes, and there's a 128, so 128 diodes. And this is we have a laboratory, so we've measured the spectrum coming out of these things, and it does peak around about 630 nanometers. You can work out some sort of standardized dosimetry so that you know from week to week or month to month how much light's coming out. And again, we don't do this every day. I think it's a 3-monthly measurement, which as things change slightly, we just alter our treatment times a little bit just to take account of the fact that the LEDs are deteriorating. But it's a simple enough thing to do. Let's see what comes up here. Yeah, we are in the rather fortunate position. We do have a calibration laboratory. Now, I know everybody doesn't have that. Our calibrations are traceable to National Physical Laboratory. We are UCAS accredited, which means we have an international recognition for making UV measurements, so that we can make our own measurements, and we also make measurements for other people, the senders, their radiometers, and we do an absolute calibration on their devices. But you could send your meter off to, we're not the only people that do this. There are several people around the world that have calibrated laboratories, and you can get a calibration certificate that will tell you exactly what your meter is measuring. So the process is you put up some sort of light source. This is set up for a different experiment, obviously. So these are fluorescent lamps. They're UV lamps. We have a double grating monochromator in here, and then we have other various meters that we're trying to calibrate. This device here, this double grating monochromator, this is calibrated. It's traceable to National Physical Laboratory. And because we are UCAS accredited, we are inspected every year and every 2 years by the National Physical Laboratory, who send one of their measurement experts in, and they go through us with a fine-tooth comb. They always find something wrong. It's never anything wrong in the actual measurements. It's more in what's called uncertainty. Now, I don't know if you've come across uncertainty, but if you spend your life measuring things, you begin to realize that there is a lot of uncertainty in what you're measuring. And what they will find is something that we haven't taken enough account of. So how do you know how uncertain you are? So this is what we always have to show, just how uncertain we are. And we have to show our uncertainty budget, which takes up an awful lot of time. You can almost guess it. Before we had UCAS accreditation, I guessed our uncertainty was 10%. It turns out it's 12%. Hey, I was wrong. So anyway, that's what we're doing here, and you can get your meters calibrated. It has to be properly calibrated. It's no point just taking a meter and saying, oh, it says it's calibrated, because meters do not have a flat sensitivity spectrum. They peak at different wavelengths. So they have to be calibrated according to the light source. But once your meter's calibrated, you don't have to do that all the time. Send it away every couple of years and somebody will check it out for you. Now, this is just showing you a grid. This is 1 centimeter squares, and we're looking at the light output from the 128 device. We got our meter calibrated. We calibrated our meter, and then we did measurements over a little simple grid to see how uniform the light distribution is. So you've got a patient, you want to expose some sort of superficial cancer, BCC or whatever, to light from this device. How uniform is your light? Nobody's going to tell you. You're going to have to measure it. So this is what we found with this device. Just normalizing to 100 in the middle. You can see we've kind of color-coded to make it a little bit easy. You've got to be careful how big a lesion you're going to treat with this device now, because the light is definitely dropping off 1 centimeter, 2 centimeters away. And you can't tell with the human eye. But if you make this measurement, you can begin to put restrictions on the size of lesion that you can measure. Or say, if you're treating with a large lesion, you have to treat a little bit longer, because out at the edges, they're not getting as much light as they are in the center. So you make your measurements, and then you have to do some calculations as to how much light your tumor is being exposed to. So it's a little bit of number crunching, but it's not difficult. I'm sure you could do it. It's quite simple, quite straightforward. It's not rocket science. And that way you can begin to produce reproducible PDT dosimetry. You know what you're giving, what light's falling on the tumor. And that's the beginning of the problem solved. That's that bit of it solved. Once you can say, yep, I know how much light, so many joules per centimeter squared. I read papers, and they're all saying, oh, we give 100 joules, we give 20 joules. I don't believe any of it. You know, the older I get, the less I believe of these papers. How do they know what they're giving? Oh, because the machine says it. Oh, right. Oh, well, that'll be right then, won't it? So, yeah, okay. This is the little one, the 16. So the little 16, you can see the uniformity there. It's actually not bad, as long as you stay kind of close to the center. So we make up these little grids and say, okay, what's your tumor? Let's say we'll approximate it to a 2 by 2 centimeter square, something like that. I've put the time here for 37.5 joules. I'll come back to that. Okay, that's 8 minutes, 24 seconds. You're always going to center on the middle of your tumor, so leave it on for 8.5 minutes, and you're going to get the sort of treatment dose you want. If it's a little bit bigger, you might have to use a longer treatment time. I mean, that's 10.5 minutes. Yeah, you can treat 3 by 6 centimeters, but you're going to have to use a longer treatment time if you want to give that same treatment dose. So you need to know what's coming out your device. You need to make some simple measurements. It's a nice little summer project for a student, you know. It's relatively straightforward to do. And then you can say, yep, I know the light I'm giving. And you can work at the 37.5. That's the recommended dose that Galderma give for Metvix. We don't happen to use it. We use a much higher dose, and I'm going to go on and talk about that later. In fact, when we switched from ALA to the Ester ALA, which is the Metvix form, we kind of initially dropped our dose to 37.5 because that's what Galderma told us to do. But we found that we weren't getting the clearance rate, so we bumped it back up again. I'll talk a little bit about that later on in the talk, because at the moment we're talking about the light falling on the tumor, not what happens underneath the skin. So we'll get onto that in a minute or two. By the way, if you want to interrupt me, please do so. I mean, if there's somebody from Galderma here who says, this is ridiculous, you can't talk about all this stuff, we know what we're talking about, please just come on, say something. I don't mind. You can be controversial, you can disagree with me. My wife does, my kids do, everybody does, so I'm used to it. Now, this is another sort of project that we run. As I mentioned the other day, we do quite a lot of PDT in the brain. And for this particular treatment, we put a little balloon filled with intralipid to scatter the light. and one of our technicians goes up. There's a treatment carried out in theatre, and then daily we hook the patient up to the laser and give them another daily dose of light for about 5 days, as long as the patient's in the hospital. Now, you might say, do all these extra days of illumination help? I don't know. Doesn't seem to do any harm. The patient's there, the laser's there. Why not just connect them and give them a few more joules? So that's what we do, because, yeah, it might help. But the challenge here is uniform light dose. This is the device we use. It's a pediatric balloon catheter, in case you're wondering what it is. Block off the end and fill it with intralipid, so you get light scattering. But of course, we started doing these treatments, and I just work out treatment times, and I give them to the theatre staffs and say, treat for whatever, and they do it. On the assumption that we've got uniform light. Well, what else can you do to begin with? But eventually we get a summer student along and we say, we've got a great project for you. I want you to measure how uniform the light is around this balloon, because we're assuming it's uniform, because we don't know what else to do. So this is what we did. I'm showing two here. This is the pediatric catheter, which is the one that we use. We use this just because you've got them in the hospital. They're there anyway. So they're easy enough to get hold of. But we also looked at the MedLight balloon catheter, which is purpose-built for PDT to give you to fill out into a balloon and scatter the light. Because, yeah, maybe that's good. Maybe that's better than what we're doing. We then had to work out how to make these measurements. So essentially, you fill up your balloon, you make it into a circle, or as much of a circle as you can. You've got a fibre sitting at the side. And then you want to make some measurements to assess uniformity. Now, there was two different things we're thinking about. One was, well, supposing you think about the equator around the middle, how uniform is it round the equator? And that's one metric that we try and measure. And then the other thing is, well, what is it, how does the top, well, not the top, let's call it the tropics, the Tropic of Cancer and the equator and the Tropic of Capricorn, how do they compare? So what kind of uniformity do you have from north to south? So we just made up a couple of little metrics. One measures the difference going round the equator, and the other one measures the difference going sort of north to south. So I think this was the equator, that's the north to south. We didn't know what to do with these numbers, so we added them together. So that gives you a number of which is related to the non-uniformity. So the higher the number, the less uniform. So we're looking for a low number here. So we start off with a bare fibre, pediatric catheter, and intralipid. That is what we were doing until this summer student came along and made the measurements. So because of the work of this summer student, we have changed what we do. With this combination, we get a figure of 2.1. If we'll use a diffuser instead of a bare fibre, but without intralipid, okay, because that's what we thought, well, maybe you don't need intralipid if you use a diffuser. Well, it wasn't any better. So we thought, okay, what about a diffuser and intralipid with the pediatric catheter? Yeah, that makes a difference. Now we're down to 0.5. Now, I can't say how much better 0.5 is to 2.6. All I know is it's better, and it's not difficult to do. So we use the Diomed diffuser, we use the pediatric catheter, and we use the intralipid. Alternatively, we use the MedLight balloon. Now, the advantage of this is you don't need any intralipid. You can just use saline, and you'll get a very good figure as well. So the MedLight balloon is a very good diffuser. It just so happens it means we've got to buy it, whereas these other pediatric catheters are already there, so nobody notices, and so it seems cheaper. It probably is cheaper. So we just carried on using this particular combination, but that is the alternative, to use the MedLight balloon, and you'll get a good figure of merit in terms of uniformity. Another simple experiment which has actually changed our practice. So now when we're doing our work, our PDT within the brain, we're now using this system down here, as a result of the work of a summer student. I don't know what's coming up. Oh yeah. Oh, this is just looking at a diffuser, one of these fibers like I showed you earlier, which you would put in for treating lung. Looks like quite a long one. Looks like about 5 centimeters. And we just set up another simple project in the lab. What's the variability going along this diffuser, and what's the variability going round about it? Again, as long as you're careful with your setup of your experimental setup, it's not a difficult experiment to do. Now, I've just picked out one or two figures here just to give you an idea. Let's just take 1 millimeter away from the detector. So supposing you've put this down to treat somebody's lung, it's sitting roughly in the middle, let's say. So you maybe get tissue a meter away. So we're looking at this here. This is from one end of the diffuser to the other. There's a little bit of a drop-off, but as long as you don't go too near the edge, if you say I've got a 5 centimeter diffuser, which means I can treat about 4 centimeters in length, you're actually going to get a pretty uniform result. Now, I know that this is up and down a wee bit, and we haven't put in error bars, which I know we should have done, but that's probably kind of within the experimental error. You've got a pretty good uniform line along there. Obviously, the closer you go to the diffuser, the more variability there is. As you get a little bit further away, it all gets a little bit averaged out. So they're pretty good. Now, we didn't know how good these diffusers were. You buy them, they come ready wrapped. You've only got the manufacturer's word for it. Well, they're pretty good. I think we'd all be happy with that. Oh, this is the polar diagram, just so that you can see with a different way of looking at it. One of them, that's the one that's 1 millimeter away. You're making your measurements 1 millimeter away. Ideally, you're looking for a nice uniform circle. It's not actually very bad. It's pretty good. The different diagrams are just different distances away from the diffuser. So as you get far away, your uniformity gets better, but they're pretty good. So that was rather nice. Now, we also looked at the Medlight fiber, and this looks like we've got the polar diagram again, maybe slightly better, but I'm not going to make too many claims. After a couple of summers experiments, they're actually both pretty good. In terms of uniformity, I wouldn't have any complaints about that. This was quite interesting because we took one of the Diomed fibers out of the package, and the diffuser had a little bend in it, just a little kink. Now, the question is it okay to use it or not? I didn't know. Honestly, I had no idea. So we got somebody to measure what the light was coming out of this bent fiber. Now, I know people say to me, how bent was it? I don't know how bent it was. We should have measured it. I know that. We should have measured it. It was a bit bent. So you could actually see looking at it, it was bent. So when you see looking at it, it's bent, you're now not getting a very good result. This is 2 millimeters in from the end of the fiber where we know it should be quite good. And that's reading, there's 0.5, 0.3. So that's 0.3 there. So you're going between 0.3 and 0.5 in terms of arbitrary outputs. So that's, well, it's almost, it's like a 100% almost difference between the highest output from the fiber and the lowest output. That's not very uniform. So I would say if you have a look at your diffuser and it's bent, don't use it. Send it back and say, I'm not using this because I don't know how bent it is, but I know potentially we could have a non-uniform light output. And if you want to ask me for these results, I can send them to you, just to support your argument that you shouldn't have to use a bent fiber. It's not quite good. Now, something to think about dosimetry. This used to get me. I don't know how many of you do PDT on the skin. And if you do PDT on the skin, do you look at the fluorescence? If you do, you'll see something like this. This here is a device which was made up for us we've got some blue lights round about to give us a fairly uniform illumination, and a camera down the middle, and that's our spacer. It looks a little bit like the inside of a lampshade, because it is the inside of a lampshade. And so that's the skin there. And we did some work, skin tumours, 6 superficial BCCs, 9 bones disease. We'll be using the Diomed, 120 milliwatts. That was giving us 125 joules, which was our treatment dose at that time. I know it's quite high. That's the sort of picture you get from the camera. That's the fluorescence from the tumour. This is the observation I want to highlight at the moment. The fluorescence was highly reduced. In other words, it got very, very dim after 100 seconds, which is only 12 joules. Now, bear in mind, our regular treatment dose was 125 joules. And in fact, you couldn't see any fluorescence after 300 seconds, 5 minutes, and it's still only 36 joules. So the question is, if the fluorescence is gone, is there any point in carrying on with the treatment? Why not just switch off and get another patient in? Why are we treating for 125 joules? So that was one question that made me want to reduce treatment time. But you will obviously have guessed that there's something else. There's a but coming up. Anyway, before we get to the but, this is just a picture of a lady with an area of bones disease, and that's the fluorescence there. It's not the best picture. PP9 absorption, you probably all know this, so you've got a number of wavelengths where you can pick out your peaks. Can we now make something out of looking more carefully at the fluorescence from the patients? On the one hand, skin fluorescence would tell us we're treating too long, but, well, I'll tell you what the but is. If you do PDT on the skin, it's a little bit uncomfortable. It nips. And it doesn't stop nipping after a minute or 2 minutes. It nips less, but it still nips. So, okay, surface fluorescence has disappeared, but there's still something gnawing away at the nerve endings. Okay, so there's still something going on within the tissue, within the lesion. So you've got to ask yourself, right, I'm not seeing any fluorescence, but is there still PDT deep within the tissue? Because there's still something hurting. Now, and hurting isn't the same as working, but there's something going on down there. So we're beginning to not be terribly sure. Should we cut down the treatment time? Should we increase the treatment times? What on earth should we do? So we start to measure the decay in fluorescence. And this was the result of quite a lot of measurements. So we've put them together. Before treatment, this is the nice peak that you get, 630, and another one round about 700, thereabouts. Really nice. Halfway through treatment, with the optical biopsy system, you can't see this with the naked eye, but there's still a little bit of fluorescence there. At the end of the treatment, looks pretty flat to me there. So it does look as if the fluorescence is gone by the end. Halfway through, yeah, there's still something there that the OBS system's picking up. Sorry, OBS, optical biopsy system. So that's just something happening.
Dr. Moseley.
Yes.
Excuse me.
Oh, sorry.
When you are shining, so the blue light.
I always look to where the voice is. Yes. Yes.
Just for the whole audience to hear me.
Yes.
When you are shining the blue light for the fluorescence PP9 detection, aren't you targeting a very shallow thickness of the tissue?
Yes.
And at the end, we want to irradiate longer. So probably you are not targeted the whole PP9 that you have in the lesion.
You are absolutely correct. And we wanted to use 405 and 630. And we wanted to use these two wavelengths to see how, if we could tease out the superficial from the more penetrating. And we did one or two experiments which worked at 630, and then when we started our proper study, we couldn't get fluorescence using the 630. It was too weak. I don't know what difference it was, but yeah, it's a good question. And I'm actually going to hit on that point later. So I'm glad you brought it up. Excellent. Now, we're looking at the rate of decay of the PP9 fluorescence here using 405 nanometers, and the point is well made that you're only looking at surface fluorescence. And that's the same when you use what we call a Woods lamp, which is just a UV violet-colored lamp, which is used just to see if you can see fluorescence. Again, that is using a short wavelength. So that's a good point. Now, what we did here was with some patients. Now, this is what we were wanting to do that was different. We wanted to get real data from real patients. Now, that requires a lot, certainly in the UK, we've got a lot of ethics committees to go through, even although all we're doing is measuring fluorescence. It took almost 2 years to go through the ethics committee and convince them that measuring fluorescence isn't causing them any danger. We are very, very tightly regulated in the UK. So, normalizing all our patients to the fluorescence at the start, the fluorescence halfway through, and the fluorescence at the end. As anyone can see, that is clearly an exponential, isn't it? You only need I don't even know. 2 points, I would say, is generally enough. But if you want a third point, okay, have a third point. Now, the reason that we fitted that exponential was that people who know about these things said, yeah, it's exponential. Well, they assumed it was exponential, to give them credit. So we thought, yeah, we'll assume it's exponential as well. So we fitted an exponential curve to these points. And yeah, that was a little bit of a weakness in the thesis. The chap who got this, Ronan, who did this work, he did get his PhD, but he had to admit, yeah, it's a little bit weak at this point. But actually, as I stand here, we are filling in the points at the moment. We're doing more patients to fill in this point. I'm not sure, because I haven't crunched the data, whether it really is exponential or not. But maybe next year I'll be able to tell you. Anyway, let's assume it's exponential. So we fit an exponential curve to this. Just as an aside, my belief is things are either exponential or a straight line, and that's it. Any more than that, I don't do it. So now we've got the Monte Carlo model. Monte Carlo random transfer? Radiative transfer, MCRT. Monte Carlo radiative transfer. I think that's what it stands for. I'm trying to remember now. So here we are. This is our model. This is the surface of the skin. And this is our tumor. It doesn't look awfully like a tumor, but remember, this was our first attempt. The chap had to get his PhD. We're now moving on to more realistic tumors, but it's going to help us quite a long way. We're going to answer questions before I'm finished that you hadn't even thought to ask. And one of them's got to do with this business of 405 nanometers versus 630 and so on. Right, that's our tumor. It's a little cylinder sitting inside the skin. XY is the surface, Z is the penetration into skin. Now, those of you who have done Monte Carlo will know what it is. Those of you who haven't probably don't have much of an idea. What you do is you drop photons into your tissue, and you just put lots and lots of photons in. And I think it's called Monte Carlo because it's all chance what happens after that. So you've got various parameters that you feed in, such as scattering coefficient, absorption coefficient, angular deflections, and all this sort of stuff. And then there's various probabilities that some of these events will happen. And every photon comes in, and it's another roll of the dice or another twin of the roulette wheel as to what happens to that individual photon. And if you do enough of these, then you build up a picture of what's really happening. Because one photon ain't going to tell you what's going to happen. But once you've got 10,000, 10 million or something like that, you've now got enough photons to be able to say, I can now see what's happening. So we're looking at the top, and we're saying, right, I want to interrogate different depths within my tumor, so I can look at what's happening at the surface. I can look at what's happening a little bit deeper down, a little bit deeper down, and a little bit deeper down. Because I've got now individual photons and I can see what's happening to them all. For those of you who like this kind of thing, here it is. You launch a photon, it does various things, and there's various chances that things happen, and then something comes out the other end, and that photon gets absorbed, does PDT, does fluorescence. So it gets very interesting. We've got a model here that doesn't just put photons into tissue. We've also got PP9 in there, and the PP9 is in the tumor. So we've got PP9 absorption, so some photons will be absorbed by the tumor. Some of these photons will produce singlet oxygen. Some of them will fluoresce. So in our model, we can look at singlet oxygen production within the tumor at various depths within the tumor, and we can also look at fluorescence. And when we're looking at fluorescence, we're launching 405 nanometer photons, to come back to your question. So we're launching in 405 nanometer photons into the tumor, and we're looking at fluorescence. We're seeing where it's occurring and how you can pick it up at the surface. And we're also launching 630 nanometer photons, which is our treatment wavelength, into the tumor. And we're seeing where that's going. And we're seeing singlet oxygen production by the 630 nanometer photons. So we're seeing both of these things going on within this model using patient data. So I'm going to run through a few results here. That's maybe too much to put in the one presentation, but I just find it so exciting, and it's pretty recent that I'm still grabbed by it. If you look at fluorescence, this is where the fluorescence is coming from at the start of the treatment. Now, we're tagging our photons, so as the photons come up to the surface, we know where they've come from. Because you can do that in a Monte Carlo model. You can say, when I look at the surface, I don't know where the photons have come from. I can just see fluorescence or not fluorescence. But in the model, you can say, right, this photon came from a certain depth, this one came from another depth, and that's what this is telling us. So this is a logarithmic scale, and we're seeing right at the start with 405 nanometers, a lot of photons coming from the surface, some photons coming from deep within the tumor, and that's what that line is telling us at the moment. Switch attention over here. This is something more similar to what's been done before, looking at singlet oxygen production within the tumor. So this is at the start of treatment. There's a lot of singlet oxygen at the surface and not so much deep down. That is our cylindrical tumor embedded in skin. But what we're also seeing is fluorescence. Right, 37.5 joules, which is the treatment time treatment dose Galderma tell us to use. And there's something incredibly interesting is happening now. Yep, the fluorescence is certainly dropped, and you'll notice it's kind of pretty flat now. There's quite a lot of fluorescence coming from within the tumor as opposed to the surface of the tumor now. That's quite different from what we saw in the previous slide. The other thing, which I think is very exciting, looking at these things together, there's no singlet oxygen at the surface, but we are still getting singlet oxygen within the tumor. The reason for that is we have photo-bleached out the PP9. Remember when you go through this production, producing PP9, singlet oxygen, some of that singlet oxygen reacts back to the PP9 and destroys it. That's the phenomenon called photo-bleaching. So you destroy your PP9. All of the PP9 has been photo-bleached and it's destroyed at the surface, but it's not finished deep within the tissue. So 37.5 joules, that's pretty weak fluorescence. You ain't going to see that. There's still singlet oxygen production going on. 75 joules, which is the dose that we have ended up with. Actually, none of the fluorescence is coming from the surface. Any fluorescence, which you could see if you had very, very good eyesight, like, Superman or something, that's coming from within tissue. And if you look over here, nothing happening up there, but still you're producing singlet oxygen. You're still destroying tumor within the tissue after the fluorescence is gone. Now, there's one or two publications that have come out in the literature in the last year or two saying, use fluorescence as your guide. And I know that when we started doing work, we were up against this a lot by people saying, use fluorescence as your guide. That's the scientific way to do PDT. Is it poppycock, the scientific way to do PDT? Of course it's not. Your fluorescence is gone. You can't see fluorescence, but you're still getting PDT. So you get the point. So yeah, fluorescence is quite good, but it's not the whole story. So this to us was a very interesting finding. If you want to wait for 150 joules, you probably should. But again, it depends how deep your tumor is. Virtually no fluorescence. You're still getting some singlet oxygen production deep down within the tumor, which I think is quite amazing. So if you put all this together, these are the curves we saw before, fluorescence being produced at different distances within the tissue. And this is this is putting all those together, which is the total PP9 fluorescence against dose. So at the start, if you're looking at the surface, you'll see 1 times 10 to the power 4 watts of fluorescence. And as the treatment goes on, you're getting less and less fluorescence. And at some point, I'm not quite sure where it is, we haven't done the experiment, where does the fluorescence disappear in relation to this figure here? And it's somewhere round about this level here. So from this point on, you're not seeing fluorescence because it's too weak. But singlet oxygen is still being produced. And this is just presenting the same data in a slightly different format, which hopefully pulls it together and makes it more meaningful. So here's singlet oxygen. If you only give 2 joules, this is all you get. If you give 37.5 joules, you're on the red. 75 joules, you're on the green. 112, you're on the dark blue. 150, you're on the light blue. And notice what's happening. Yeah, you've produced singlet oxygen at the surface up here, not at 2 joules. You've got to get at least 37.5 joules. But what you're now doing is you're pushing your treatment deeper into the tumor. That line there represents what is generally been accepted in the literature as your therapeutic dose. I can't remember, it's 0.8 times 10 to the 17 singlet oxygen molecules per centimeter cubed or something. It's a slightly arbitrary number. You could probably put that line up or down a bit. But we've taken it as a reasonable metric. That's our guide. We want to be able to do that in order to get cell kill. And you're pushing deeper and deeper. And again, this is just the same data represented differently. You'll get down to 3 millimeters over 100 joules, a little bit beyond if you go even further in terms of the dose. So we're just trying to find different ways of presenting the data just to make it clear that you keep your light on longer, you get deeper into the tissue. It doesn't cost much just to keep it on a little bit longer, and you'll get more penetration. So, should observation of surface be used as a marker for effective PDT treatment? I'm not answering the question. I hope you can answer that question. We advocate an increase in treatment time after surface PP9 fluorescence has disappeared. And these are the sort of treatment depths that our model is telling us. And the model, remember, comes from patient data. If you increase the dose all the way from 37 up to 150 joules. Now, maybe I should stop at that point, but I've got more data that I would like to present. What do you want me to do? Do you want me to keep talking, or do you think you've... Well, I'll be led by you. I'll give you some more results. And if you get a little bit sort of, too many figures, whatever, that's fine. That's okay. Coffee will be soon. How do you compare different light sources? Now, there are all these different spectra from different lights. So what are they all doing? How do you work out what light dose to use with all these different light sources? Hey, Monte Carlo model is going to come to our aid again. These are normalized spectra from different light sources. These are all light sources that we use for treating patients. So that's why I say this is really something that we wanted to know. We needed to know these results. We weren't doing it just for the sake of doing it. These are, to us, useful data. Now, you've seen this sort of thing before. We're looking at singlet oxygen production. When I say before treatment, right, this is before you begin to do any photobleaching. And you get it's a snapshot. It's probably this in itself isn't terribly useful because what you want to know is how much singlet oxygen have you produced right through the treatment. So this is a snapshot at the beginning. These two are the photocure and the Waldman lamp. The Waldman lamp's a great big beast. It's enormous. You can treat half a person under one of those. and then we've got these there, which are smaller and more focused around about 630 nanometers. At the end of treatment, again, a snapshot at the end, and you can see with all these light sources, you're still getting some singlet oxygen being produced. To some extent, that's interesting, but what is the total effect during the course of the treatment? And that's shown in this slide. Again, this is the same presentation as as you saw before. If you pick out 75 joules, which for some reason, I think Ronan was nearing the end of his PhD, so he didn't go into higher doses. So he went up to 75 joules. You can see here's a light source here, and you can see, yeah, you're getting a bit of penetration, and here, but not as good as these two. So we've got two lamps here, which are certainly outperforming these two lamps, joule for joule. So this was useful. We needed to know this. Because these are real lamps that we're using in the clinic. We'll lay that to one side because I think that in itself is a useful result. You can see I'm rattling on a bit now. What about monochromatic light? Why should you use 630? Just because somebody said, oh, there's a peak away out at 630, use it. Why not use one of the other wavelengths? Why not use 405? If you're treating actinic keratosis, for example, you use 405 nanometers because it's absorbed closer to the surface. Well, this is the snapshot of singlet oxygen production by these different light sources. You can see the 405 getting a lot of singlet oxygen at the surface, not penetrating deep. 630, not much singlet oxygen. Yeah, you're getting deep. So overall, what's the best light source to use? This is at the end of your treatment after you're given 75 joules. Again, it's a snapshot in itself. It's not telling you very much. And you can see the 405 up there and the 630 down here and the other wavelengths in between. I think this is quite useful, presenting the results like this. If you just take the 75 joules, there's your 405 nanometers, treating down to 2-something millimeters. 505, 75, you're pushing it a little bit deeper. 540, a little bit deeper. 575, a little bit deeper. Oops, sorry. And 630, deeper still. And this puts them all together. So there's 405, and there's 630. Now, if you're only wanting to treat a millimeter or two, 405's fine, it'll do it. You don't need 630. You only need 630 if you're trying to get deep down within tissue. And that's why 405 is a good choice for treating actinic keratosis. What about beam diameter? There's a feeling out there that the wider the beam, the more penetration that you get. And I'll explain the reason for that, which is if you're using a small fiber, that is true. The difference between 0.5 millimeter and 2 millimeters is quite significant. And we were talking, coming along here, about treating veins with KTP laser. And there's quite a difference between 1 millimeter and 2 millimeter fiber. So at that, when it's a small diameter, it does make quite a difference in penetration. Once you get to 10, 20, 50 millimeters, it doesn't make any difference at all. So we tested this out using good old Monte Carlo. This is after treatment. It looked very different in all of these. And in fact, you're hard-pressed to tell them apart. Yeah, 50 is a little bit better than 10, but to be honest, there's not an awful lot of difference. So the beam width, provided you're covering the tumor adequately, don't skimp at the edges, because we know from our clinical experience, if you skimp at the edges, the edge of your tumor will not be treated. But in terms of treating down at depth, it doesn't make much difference. I'm almost finished, you'll be pleased to know. I think this is the last thing we looked at, which is what happens if your tumor's not at the surface? And can you drop your tumor a little bit deeper in the model and see how much depth within the tumor you can treat? And that's what we did here. So we had a tumor sitting at the surface, and that's the sort of how far into the tumor we got. What if the tumor's sitting 2 millimeters below the surface? Well, you don't actually do very much at all. So this is giving us a good idea of, supposing your tumour's under the surface, can you still surface illuminate, and can you get sufficient kill within the tumour? And if we spent more time looking at these figures in detail, you would get a good idea as to what we could treat for an embedded tumour within tissue. This is a kind of summary slide. This is this threshold photodynamic dose that I was talking about earlier. That's our kind of what we want to get, because we then reckon we've got enough cell kill. We're using 75 joules. The optimum non-laser source, well, there's two of them. There's this thing called the partisan lamp and the Actolite that go down to about 2.7 millimeters effective depth. Monochromatic, the 630 will go down to about 3.8. See, the 405, it's not, 2.2 millimeters. Don't write it off just because, it's not penetrating as far as the red, but it can still be quite useful. Beam diameter doesn't make any difference. And then this was this business of deep-seated tumours. If your tumour's not at the surface, you can possibly still get some effect if it's still a fairly thin tumour, but it gets more and more difficult to get a useful treatment dose, and that's just saying what I said before. Oh, I just want to finish with this. I should have brought some flyers along. I'm sorry I left them in my office. Laser Europe 2013. It's next month. I know there's not a lot of time. It's in Manchester. We've kept, the program is full, but we have kept one session for late abstracts. So there will still be a possibility of getting a late abstract into the Laser Europe meeting in Manchester in May. Now, I know you all can't come, although it would be lovely to see you all over there, but maybe some of you could come over and get a late abstract in as quickly as you possibly can while that session is still got space. And I'll tell you one thing about this meeting in Manchester. We're having our conference dinner in Old Trafford, which is the home of Manchester United. Now, I know you play a little bit of football over here as well, but if you want to go and see how football's played in the UK, you come over to the meeting in Manchester. I don't think there'll be a game on, but we will be having our conference dinner in the home of Manchester United. And that's about it. So, thank you very much. Thank you.
It seems like you were focusing on doing high power for shorter periods of time. And I'm wondering if you switched that around so you were doing lower power for an extended period of time, what the experience in pain would be for the patient, whether it would improve or inhibit healing, if there would be any change in the absorption. Basically, why do you choose the short times?
That is a really good question. I don't want to say which was the better question, the 405 or your question, but they're both very good questions. We know clinically there's less pain if you reduce the power. We know that. It doesn't go away entirely, but it is much reduced. It's also been shown by numerous other workers that you'll get more efficacy at lower power. So lower power is more phototoxic than high power. The assumption is that you're depleting the oxygen supply with the high power. So if you reduce your power, you'll get a better outcome. There's a compromise here. When you're in the clinic, you can't be having your patient sitting there for 2 or 3 hours with a lamp on. You've got to get your patients in and out in a reasonable length of time, and that's why we're using a power which is well tolerated by the patient, but still allows you to get the treatment done in about 20 minutes or so, rather than 2 hours. And we have done the 2-hour treatments. It takes a very long time. However, if I was doing another talk on light sources, I would show you one of the sources that we're using, which does use very low power, and that is actually giving us very good results. It's giving us just as good for much fewer joules than a high power. Why have I not talked about it today? In the Monte Carlo model, we said to Ronan, model this, give us lower power, and let's see the outcome. He modeled it, and it was identical. And we sat and looked for 2 weeks, scratched our heads, and we said, we know why this is, because the model cannot take account of oxygen supply. We have to assume a an availability of oxygen in the model. We cannot get any data. We'd love to get in vivo data to tell us the availability of oxygen. We've got another PhD student at the moment, and she's still trying to get this data. It doesn't exist. If you could begin to feed in the availability of oxygen into the model, mathematically it's trivial. It could be done in 20 minutes or less. But the data's not out there. We just have to make it up. And then we weren't quite sure if there was any value in that. So the reason that hasn't been featured in the model is that there is no information that we can put in. But if you're doing this work, or if you go back to your lab and get the data, then please let us know, because that would make a huge difference to the model, allowing us to put that into it. But it's a very important point. Why don't we use lower power? And I think hopefully I've given you a satisfactory answer.
Can I ask a follow-up?
Oh, go on.
If you were able to do this lower power for longer periods of time, do you think it would be possible to have this be an at-home treatment if you could send them with a portable source?
Yes. We first published this about 3 years ago. We called it ambulatory PDT. And we produced our first pilot study. And it was based on the concept of patients having their treatment at home. We use a strap-on device, LED, but just to be sure, we actually kept them in the hospital. But now they go home. So we have moved to patients treating themselves at home. In fact, more than that, although I'm not giving the talk just now, you can use daylight PDT. And this has been pioneered in Denmark, and we're now doing it as well. Provided you've got enough light out there, you can do daylight PDT, which means your patient doesn't even need to stay in the hospital, doesn't need a light source other than the light outside, but you've got to watch for sunburn. So that's a limiting factor. You've got to use sunscreen to make sure they don't get any sunburn. So again, there's a lot of different things we can do with light sources, and we're just scratching the surface. The other thing is fractionation. If one of the limiting factors is the availability of oxygen, then it's already been shown in mice. The results in humans are maybe not so convincing, but why not treat for a bit, have a pause, let the oxygen come back, and treat for another bit. So there's a lot of stuff we could do. We just need better data to feed the models and also to change our clinical practice.
Thank you.
Okay, you're welcome. Thanks.
So also concerning your model, because in the clinics we face some difference in the optical characteristics of the tumor lesions, like the absorption. There are like pigmented BCC and non-pigmented. So what do you think about also those properties, tissue properties in the model?
Yeah, we have tissue properties, but they're sort of average tissue properties. We don't find that BCCs tend to be pigmented much. Obviously, the melanocytes are totally disturbed. The epidermis is not really a normal epidermis. We don't have much experience of treating dark skins in Scotland. Most of our patients are light-skinned. In fact, in the UK, BCCs in dark skins don't happen very often. But I understand, because we were chatting about this the other day, you do see quite a lot of BCCs in the skin types you have here. Is there much melanin in a BCC over here? It can be. Yeah, well, that's another variable in the model. I mean, it's easy enough to change these properties. We just went for a kind of skin type 1, 2 average because that's our patient population, but it's easy enough just to change some of these parameters, and that would be well worth doing. Yeah, we should talk about that. Yeah. Wait a minute, hang on. The voice
we
in
even
the
have
sky.
here in Brazil BCCs in patients phototype 3.
Yeah, and phototype 3, yeah. You've obviously got, well, I suppose it's a kind of European skin type, a lot of people have, and the Japanese skin types as well. You've got a few of those.
More questions? Let's thank again, Professor.
Thank you.